everybody, and as the panel said, it's a pleasure to see so many faces here this morning at the conference. For me, it's a great pleasure, privilege, and an honor to be invited to this conference, and I thank all the organizers for the wonderful work and hospitality they've offered. So I bring you greetings from New Zealand, Aotearoa in our native language, which means land of the long white cloud. We have a lot of cloud in New Zealand, so we have plenty of rain, so this experience this morning is nothing new. So this morning I'm going to talk about an interactive model as an e-learning platform for clinical reasoning. But first, just a slight geography lesson. I'm sure everybody knows where New Zealand is. Many people confuse New Zealand with Australia, which is very, very bad, of course, because we love the Australians, but we are definitely a separate country. It is a very small country, which is a long way. So on Friday, I faced 36 hours of travel to return back to New Zealand. My city is Dunedin, which is in the south of the South Island. So even when I arrive in New Zealand, I have further travel. My university is almost 150 years old. It is the oldest university in New Zealand, and it has a strong reputation in the medical sciences. Just a little bit about the background to this course. The course I'm going to describe is a postgraduate course for practicing pharmacists. But equally, the concepts can be applied to the whole of medical practice, to physicians, to nurses. And the point here that modern pharmacy practice in New Zealand is the pharmacist is actually part of a multidisciplinary team. They're a team member, they're involved directly with patient care, in primary care and secondary care, and they provide clinical services. They work in hospitals, in primary care. Some of them have limited prescribing rights. They conduct medication reviews, and they have advisory roles. So they have a very integral part in the healthcare structure. So the context of this presentation is that it's really referring to a pharmacist postgraduate course, and those pharmacists are actually working in practice, so they can apply the learning as they practice. They also use this course to develop and maintain their competence. They use it as part of their continuing professional development. There is the potential to use this technique for physicians in primary care, for nurses, and in fact we're exploring how we can develop these courses to actually include a range of health professionals, so we get the input from the different professionals in the case discussions. We can also use this technique in undergraduate education, and this whole idea fits with the National Medicine Strategy to improve education of health professionals on how to manage medicines optimally. So if we can define the clinical reasoning, it's used interchangeably with a number of terms, such as clinical judgment, applied critical thinking, and clinical decision making. So really, it is the process of synthesizing clinical information, planning and evaluating options, and applying this to a specific patient. So some of the context is that we are dealing more and more with complex patients, with comorbidities, with lists of medicines sometimes in double figures. We're also then in the situation where we have to look at the evidence, which is often from really defined populations, from clinical trials. So that process of synthesizing the information and applying the evidence to the individual patient is becoming very important. Again, clinical reason is an advanced cognitive skill that integrates a reasoning process. It's the ability to think through a problem. As I said, problems are becoming more and more complex. What has been with knowledge, integrate this with knowledge, what has been learned about the problem, and arrive, this is the important part of course, arrive at the decision, the best decision for the patient. As far as clinical reasoning, it's really implicitly part of medical practice. Nursing, it's explicitly required in some competence programs for nursing. And in pharmacy, as I said, it's becoming more and more important. And interestingly, from the research point of view, much of the initial research is from the nursing literature. So nursing education has made great strides in education in this area and in other educational aspects. Most of the texts refer to clinical reasoning in the context of all health professionals, not just for physicians. So it is across those boundaries of the professions. So what I'll do briefly, and keep to time, is to describe an innovative teaching practice which was designed to develop clinical reasoning skills for pharmacists in a postgraduate distance education program. Most of this program is delivered online. We have one residential workshop at the start, and of course this particular part, the clinical reasoning part, is only part of the full paper. And this model, which I'll describe, can be used to educate all health professionals. We use a structured model, and we move initially from inductive reasoning, where there's a lot of uncertainty. At this stage, we encourage students to basically discuss with free will, to put forward their ideas with no boundaries. There is uncertainty, they're just discussing lots of considerations and lots of options. So we call this really the inductive reasoning process. And then we move down and we finally arrive at deductive reasoning, where we actually ask the students to make a series of decisions about the patient care. So first of all, we identify all the problems that the patient may have. Secondly, we do an in-depth assessment of the evidence. Now this is the key. We want students to look at the available evidence and, if possible, apply that. So they have to justify the decisions as well. They then set goals which are patient-centered. They explore different management options, including drug therapy. They also assess the impact of each option, and then look at the final decision, and then reflect on that as a learning process as well. The actual methods, as I say, we have at the moment, the paper I'm involved with has 40 students who are distributed throughout New Zealand. They are students working in primary and secondary care. And we use an interactive group discussion process where we post cases online. Of this, we have two stages. One is problem identification and prioritization. And the second stage is the clinical reasoning and the decision-making process. Now, the assessment, I think, one of the challenges with this type of exercise is the assessment process. Now, this component of the paper is just one part of the paper. In this particular exercise, we have a group exercise, and we have a group assessment that is performed by 3 tutors. Also, and interestingly, we ask the students to do a peer assessment. They self-assess their contribution to the problem, but they have to provide evidence that they've made a useful contribution to the process. And then we also get a peer assessment where students assess each other's contribution. So we post the cases online onto a discussion board. We have groups of 4 to 6 students. We're not sure what the ideal number is. It's probably 4, but sometimes due to student numbers, 6 still seems to work. The case gives the background information, including the social history, the medical conditions, and we tend to use complex cases, which represent a lot of the cases we see. Cases with several, sometimes 5 or 6 comorbidities or more, and maybe 10 or 12 medications. We provide the drug history and then also some information about the patient's perceptions, their current complaints, their current concerns about their health. This is only part of the case. The case is usually at least 3 pages long, where we give that information, very detailed information. We currently use a Blackboard learning management system, but this would work in any interactive environment. So, for example, with Moodle, with any learning management system, and it doesn't have to be sophisticated. You can almost do this by an email, simple email discussion. So the cases go on board and on the discussion board, and the students then discuss those cases through a structured approach. They discuss them, and the moderator, I'm one of the moderators, will look after the group and maybe at some stage, maybe point them in a specific direction. But in most situations, we found that the students are very motivated and they will really work on this themselves. When we come to the assessment and presentation, so we give the students some time to discuss the cases. We use Zoom, which is a video conferencing facility. That is really good because it gives us, even with 40 students, we can actually share screens. The students can prepare PowerPoint presentations. They can see each other. They can interact by facial recognition with the tutor. It's a very good system. And we have found that with 40 students that the bandwidth is actually very reliable, and we find it a very good process for presentation and assessment. So the first stage of the group work, as I said, it's a think aloud. The students just basically go for it and discuss. It's a think aloud process. And the idea there is to go through the patient's list and identify the problems, and then look at the evidence around those problems as well. And then actually prioritize based on clinical importance. So in the problem identification, we're very much here putting the focus on drugs and medicines and the associated clinical conditions. So they're reviewing and identifying all the potential problems, but looking at the potential adverse drug reactions of the patients. We're looking at potential drug interactions, but also things that are a little bit more difficult to identify, such as missing drug treatment, a condition that is not being treated that could be treated with medicines therapy, or maybe a condition which is being inappropriately treated. Or maybe there is a drug there that has no particular indication for its use. So we class these in total as drug-related problems. We then ask the students to select 5 problems. So we do have complex cases. In many cases, there are up to 10 or 12 individual problems for that patient. But we ask the students to select 5 problems for the next phase, but they need to justify the evidence base around this problem. When they come to prioritize the problem, they should also focus on the patient. What are the patient's expectations and beliefs? And how should these be prioritized to optimize the care of the patient? We need to consider the overall health outcomes the patient benefits. Many times we'll notice that the patient doesn't realize that there could be things they should be doing to optimize their health. They don't realize the importance, perhaps, of good blood pressure control. So we need to look at this in the overall picture. and then justify each priority according to the application of evidence and the patient context. That is often a real challenge. I'm sure most people who work in clinical practice, working with complex patients, to make a decision on which is the most important issue to deal with is a real challenge sometimes. In the second stage of the group work, the patients will look at setting treatment goals, exploring all the management options. So the reasoning here is becoming more and more deductive. This is where they actually practice the clinical reasoning, and then they move to the application of clinical reasoning when they finally decide on a course of action for each problem. They actually also state how the decision will address the overall health goals of the patient. So we move from practicing clinical reasoning to applying clinical reasoning. Now, as I said, the assessment, we use the students present the cases, short cases, with at 2 stages. They present after the first stage, which is setting the priority, and the second stage when they're actually coming up with the decision-making process. We as tutors, we fire lots of interesting questions at the students. We also encourage students from the other groups to ask questions as well. It's extremely interactive. And as I mentioned, students self-assess their own contributions by providing their 3 best posts to the discussion board. Now here's an example, and I don't know if you can read all the text at the back, but this is not an unusual patient that we would see. We have a 53-year-old male patient, and some of the medical conditions, I've put it short a little bit, are obstructive airways disease. They also have some heart failure, which is often a comorbidity with respiratory disease. They also have some diabetes. We notice that they have albumin in the urine, albuminuria, and a degree of renal impairment. These are not unusual patients. The patient has chronic fatigue. They also have some urinary incontinence, which is treated with anticholinergic drugs. This may be appropriate and maybe not. Probably not surprisingly, the patient has a degree of depression as well. So these comorbidities are not uncommon to see. So these are actually the conditions, but if we look at some of the problems that either are subjective or objective, the patient is breathless. They don't have good control of their respiratory disease, their COPD. Maybe there is inappropriate use of inhaled corticosteroids. We know now that these have a very specific place in the treatment of COPD. Interestingly, there is no beta blocker. The patient has heart failure. We know that beta blockers are beneficial in heart failure. This patient is not receiving a beta blocker. Maybe it's the concern about the COPD. The albuminuria, looking at the dose of the ACE inhibitor, it looks a little bit low. The patient has lots of anticholinergic drugs. Maybe this is contributing to the constipation and the dry mouth. And the patient is not responding to the antidepressant. Now this is, in our experience, this is not a fabricated case. This is actually a real case that we adapt for teaching. So they are real problems that we see. But very briefly, we could spend a lot of time discussing this. The students spend, a couple of weeks. But just as an example, we can look at the reasoned priorities for the care of this patient, which the students may come up with, but other people may challenge. But one priority would be to look at adding the beta blocker for the heart failure. And we know there is good evidence for the cautious use of beta blockers in patients with COPD. They are not contraindicated. We use a cardioselective drug, and the students can look at the literature and justify this decision. We can optimize the COPD treatment by perhaps looking at the evidence and the stage of COPD and making a recommendation along those lines. Some of the other aspects, as I say, is to optimize the dose of the ACE inhibitor for the albuminuria and perhaps look at why is the antidepressant not working? Is there a lack of non-pharmacological treatment, for example? And importantly, we're seeing more and more of this in older patients, is review the burden of anticholinergic drugs. Anticholinergic drugs cause a lot of problems in older patients and in patients with comorbidities because they have a range of adverse effects. So these are just an example of how this process can work. We get some good student feedback, which is also and always very encouraging. So students say, for example, I'm using this, every part of this course, every day in my practice. Another quote, I like the way we have to work out problems for ourselves. The students really love this approach. The best thing about this course was that it helped me realize how much I don't know and how much more there is still to learn. And actually on that final point, from a practitioner's point of view, from my point of view, I learn so much from these case discussions, and it actually enriches my future teaching. So it, in some extent, it's a two-way process. Some next steps, with any innovation, you don't stand still. So we're now looking at research, designing an instrument to measure the development of clinical reasoning skills in this student population. Actually, what we found is that the reasoning skills can be different across professions. So doctors, nurses, and pharmacists do things differently, but often it's complementary rather than actually a problem. We want to investigate a multidisciplinary model where we use this technique not just with pharmacists, but with general practitioners in primary care and with nurses, because this will be, I think, very beneficial to see the different contexts of their input. And we're very keen to share, collaborate, and learn what other people may be doing in this area. So I just need to acknowledge my colleagues. This is very much a team approach, and I need to acknowledge their contribution to this program.